We move on. I'd like to discuss some clinical aspects of the triads and dyads over there, especially the triads. So some conditions related to triads are Brody's myopathy, where sorry about that. Let's just get rid of that. In Brody's myopathy, you have a genetic defect in your ATP2A1 gene. Now, what does ATP2A1 gene code for? It codes for circa ATPase, okay? That circa ATPase pump that we studied about, which concentrates the calcium in the L tubules. So if you want to relax your muscle, you after the action potential is over from the nerve, you don't get any more action potentials. Listen, whenever you want to make a sustained contraction take place, you need to give not one action potential, you need to give a chain of action potentials in quick succession, and this is called a tetanizing stimulus. So you're not just getting one action potential. You give one action potential, you get a small flicker in your muscle. That's it. It doesn't really make any notable difference or movement. So a continuous chain of action potentials down the neuromuscular junction gives you the action potential that goes down, activating dihydropyridine, which will stimulate and release the ryanodine to release its calcium ions. Now, we have this ATPase pump circa in the L tubules, which will concentrate your calcium and take it back into the L tubules and allow the muscle to relax. Now, if your circa ATPase is not working, if there is a loss of function mutation, then you end up with the inability to take the calcium fast enough back into the L tubule. So there's more calcium, and if there's calcium, there's going to be muscle contraction taking place, cross-bridge cycling, sliding filament theory, and all that stuff. So you won't be able to relax your muscles. Your muscles are in a state of slow relaxation, and this gives you this manifests symptomatically as painless contractures. So symptomatically SX, this is like our code for symptoms and signs. Painless contractions in the muscle contractures, it stays contracted during exercise. So whenever you work the muscle out a lot, there's a lot of action potentials going down because you're exercising and giving a lot of action potentials. So that's going to cause a lot of calcium to be released, and not enough will go inside, and this is going to cause your calcium to stay in the cytoplasm for a longer time, giving you your painless contractures. Then you have central core disease. Now, what is central core disease? You have mutations in ryanodine 1 gene. So RYR1 codes for the ryanodine receptor, and what happens is there is a loss of function taking place in the ryanodine receptor, and you don't release enough calcium when you have to release calcium. So there is a decreased calcium release taking place over here. And this decrease in the calcium release is going to cause muscle weakness and skeletal abnormalities. So you get this muscle weakness and skeletal abnormalities taking place. Then you have malignant hyperthermia. So what is malignant hyperthermia? Again, you have a point mutation in ryanodine 1 gene, but here there will be the ryanodine, it regulates itself. When it releases a certain amount of calcium, it says, okay, that's enough. So it has a negative feedback on itself, so to prevent too much of calcium from being released. But here, because of this mutation, you have a defective negative feedback. So the ryanodine just doesn't know how to regulate itself and releases a lot of calcium from the L tubules, and this is precipitated by malignant hyperthermia. So malignant hyperthermia is precipitated when you expose these ryanodine receptors to drugs like halothane, which is used in anesthesia. Even succinylcholine and succinylcholine, these are your muscle relaxants. They're going to cause the muscle to be relaxed. Halothane is an anesthetic. Succinylcholine is given to paralyze the muscles. If you remember from the neuromuscular topics over there, we've done this. So these are your drugs which are used by the anesthetists and in the operation theater especially. So when you give them this drug over there through gas or injection, halothane is usually given by gas. It's one of those fluorinated drugs which we use for knocking the patient out during anesthesia. So this is going to cause a lot of muscle contractions, and what's going to happen is the muscles will be contracting, working so much, so oxygen will be used, so you go into hypoxia. Hypoxia is low oxygen level at the tissue. Okay, low oxygen at the tissue level. Hypercarbia means increased CO2 levels. Okay, just think like more CO2 at the tissue level, and this muscle contracts a lot. Okay, because of the defective ryanodine receptor, you'll release a lot of calcium, lots of cross-bridge cycling takes place, and movement generates heat. Movement generates heat, so you will develop a lot of body heat, a lot of body temperature increase. And it would be rapid. It will be more than 1 degree Celsius temperature rise every half an hour. This is dangerous. When this happens, you have to immediately stop the exposure to the offending agent. You have to do rapid cooling as soon as possible. You have to cool the person down, grab whatever fluids you can and pour it all over him. Get some ice packs and put it around the person's body, especially the head and the chest, because those vital organs are over there and you want to maintain the temperature of that. Then there's a drug called dantrolene. So the treatment is rapid cooling, dantrolene, and shift them to ICU and call a specialist for help over there in managing this patient. So these are the clinical aspects, and these clinical aspects, if you get a theory exam question on excitation contraction coupling, you can write this under the clinical aspects for excitation contraction coupling, which I will be doing now. So this is the algorithm which I've made and written beautifully for you about the excitation contraction coupling, how the sliding filament theory takes place. This is also known as sliding filament theory. So what happens is, you remember that the alpha motor neuron releases acetylcholine. You should emphasize a little bit about that. Even though this was in the previous topic, a little touch, you should touch on this topic just a little bit, okay? So this acetylcholine release will cause the acetylcholine to bind to NM or N1 receptors on the postsynaptic membrane. So you form an end plate potential on the postsynaptic membrane, and this end plate potential is depolarization, and if the depolarization is more than 25 millivolts at least, you will reach the threshold of the muscle. So it reaches the threshold and you get this action potential. So the action potential will form on the postsynaptic membrane or sarcolemma. Then this action potential propagates down to the T tubule. So you remember, from here, alpha motor neuron, you have this action potential down the T tubules where there is dihydropyridine, and this is having a foot process connection with the L tubules, which has got ryanodine receptors. Okay, remember that from the pictures above. And so we have the dihydropyridine, which opens the ryanodine because of the foot process in the skeletal muscle. In cardiac, it is calcium-induced calcium release. Anyway, so now you have the foot process, which releases the calcium. You make a conformational change in the foot process, so ryanodine releases calcium from the L tubules. Lots of calcium is released from the terminal cisterns of the L tubules over here, and this is called calcium spark. And it takes place around 20 milliseconds after the onset of the action potential in the muscle. And what happens now is calcium binds to troponin C. So the calcium that's released is going to bind to troponin C. So you have 4 calcium ions for 1 troponin C. And this is going to cause the movement of tropomyosin. Now, tropomyosin, remember, there was the actin over here, and it was covered by what I drew in green as tropomyosin, like the whale. So this moving has now exposed the myosin binding sites on top of the actin for myosin to bind to over there. So it will bind. Remember Romeo and Juliet, okay? So the myosin binding site on the actin filaments are exposed, and finally you get what we call cross-bridge cycling and power stroke. Now look at this diagram. I've drawn this cycle over here. It explains what is cross-bridge cycling and power stroke in great detail, so I hope you pay attention over here. First, I've drawn situation number A. I've labeled it as A. First of all, the first state is you have this myosin. You can see in green over here, okay, myosin. This myosin, if we see, has a head, and this head is cocked. It is ready to bind to actin, okay? This is in the resting state. It was in the cocked state. Now, you could see the angle of the head and the neck. It's 90 degrees over here, and this myosin is bound to an ATP molecule, but it's not completely ATP. It's like partially hydrolyzed. It's partially broken down. So the ATP molecule is bound to the myosin head, but it is not complete ATP. The bond is like partly broken. So myosin is in this kind of a funny relationship with ATP, where it is not completely destroyed by the myosin, but it's in the process of being destroyed. It's like semi-digested. So myosin is getting energy from sort of toying around with the ATP molecule. And what happens is, now look at this picture, this thing I've written, A plus M dot ADP dot PI. So this is the actin. It's over there. It's separate. So A plus plus, because it's different from myosin. So now you have the myosin. This is M. So this is A plus, because they're separate. They're not together. M. This is M. But look at the myosin. Myosin is in a complex relationship with ADP dot PI. Alright, so it is partially hydrolyzed. This is in the relaxed state, where the myosin has a high affinity for actin, but it just can't find actin because there is